All right, let's continue on with our myocardial infarction, acute MI, and acute coronary syndrome talk here. So let's go to clinical manifestations. So let's talk about pain and discomfort. Number one, don't just go and say, hey, are you having chest pain? Because more than likely they're going to look at you and say no, but they'll say, hey, I'm having some chest pressure. So you need to use the word discomfort. That'll get you a better response from your patient. So I always said, are you having any chest pain or discomfort? You need to ask them where it is. What's it feel like? Can they describe it? If it's sharp, hurts worse when they take a deep breath, they can point to it. It's probably not MI pain. This is pain all over the chest. It's usually heavy. Their chest could feel full. They say it feels like an elephant sitting on my chest. It will radiate up to their neck, their arm, to their jaw, could go down their arms. If it's only one arm, usually it's left. They'll be short of breath. They'll be diaphoretic, cool and clammy. That kind of freaks them out. They'll be anxious. They may have feelings of impending doom. Those are all your typical signs and symptoms. And those are more prevalent in men. Women can have different signs and symptoms. They can have fatigue. They can have diaphoresis. They can just have, some dyspnea that comes on. They might have a little syncope where they might have a little spell that they lose a little consciousness. They could have palpitations. Real common to have this nausea, vomiting, just indigestion. They're like, no, I'm not having any chest pain or discomfort, but I've got some nausea. I got some indigestion. It's worse than it's been, but I've had it. I just can't get rid of it. That's pretty common. They have pain in their back, shoulders, between their scapula, between the shoulder blades. That's a common place for women to have signs and symptoms, and then upper abdominal pressure. So I split this out between men and women because women can have different signs and symptoms, and you need to be aware of that. Now, it doesn't mean that women won't have that crushing, heavy fullness in their chest. Doesn't mean that men won't have nausea, vomiting, and indigestion. It's just if we have to split it, this is how we split it. Elderly and diabetics also have atypical signs and symptoms. Diabetics may never have pain at all. The elderly actually don't really pay attention to pain, and they're more likely to come in because they're short of breath and have dyspnea, which may be the fact that they are now in heart failure and had a MI 4 days ago. That is somewhat common for them to do that. So I've got your collaboration listed. We have all kinds of people that will come and work with them. We may or may not have respiratory therapy, and I'll talk about that in a minute, whether or not they're going to be on oxygen. We'll have our healthcare provider, a cardiologist. We may need a cardiothoracic surgeon. They'll certainly be on meds. We need to give them resources. Cardiac rehab team, dietitian, all those sorts of things. You also have risk factors listed in your outline just before your clinical manifestation, so be sure that you know these risk factors and how we are going to teach and identify and decrease these risk factors for our patients. So we have non-modifiable: age, gender, race, ethnicity, and family history. Can't change those. The modifiable risk factors: high cholesterol, high lipids. So at the beginning of your outline, I gave you the values for cholesterol that I want you to know. Hypertension, diabetes, smoking. The only answer for these people is smoking cessation. You need to quit smoking. It's the only thing we teach. Physical inactivity, obesity puts them at risk. Metabolic syndrome and early menopause, because we women are covered by our hormones and tend to have coronary artery disease later than men, but we can actually have worse outcomes because of that. So be sure that you look at those and refresh your mind on those. So diagnostic tests, what are we going to do? The first couple of things that we can look at are just general lab work. So we can get a CBC and a basic metabolic panel, a BMP. I tend to call that a chemistry, and why those are important. If your H&H is really low and you have atherosclerosis, you can have a heart attack from having a low H&H. I've seen it several times, so that's important to look at. On my chemistry panel, I need to know what your potassium is, because if your potassium is really low, you're going to have cardiac problems. You're going to have cardiac dysrhythmias like VTAC. So that's important to look at. So I think that those are the kind of basic labs we get for everybody. But if I'm going to pick one lab to determine if you're having a heart attack, I'm going to get a troponin that is cardiac specific. It increases as early as 1 hour and remains elevated for 10 to 14 days. And a normal value is less than 0.02. So that is highlighted in your notes, which means you need to get your highlighter out and you need to know what that is. It's going to be drawn at emission, and it will be repeated. Usually it's somewhere they're going to repeat it in an hour, and then in 3 hours and 6 hours, and then again in 24 hours. That is specific to the healthcare provider and specific to the facility, but they do the serial test checking those. So troponin is what we're going to get, and it's incredibly important that you know that. Now, FYI, we're using the value from the book, and when you go to clinical, depending on what clinical facility you're at, you will see different values. One facility in town uses a much more specific troponin, and so their value goes up to something like 53.5 or something like that. So we're just going to look at those values that they list. There could be other cardiac markers, cardiac biomarkers, cardiac enzymes. Those are all the same term for what we're looking at that could tell us. So if we do cardiac markers, we get a CK, but a CK is muscle damage, whether it's the muscles in all of your body, or the CKMB, which is the part specific to your heart, or BB, which is specific to brain, because if you have a stroke, those can go up. So you may see those. You do still see those in NCLEX review books, but the standard really is troponin. We're going to get a 12-lead EKG. It's important that we get that 12-lead EKG to look for ST segment depression, flip T waves, ST segment elevation. At some point in the stay, we might get an echocardiogram, which is going to tell us how well your heart pumps and give us what's called an ejection fraction. And a normal ejection fraction is 50 to 70%. But the three things I want to look at to know if you're having a heart attack, you should write these down. You should put a big star on them. You should highlight them, and you should memorize them. The three things you're going to look at: I need to know your signs and symptoms, I need to know your troponin, and I need to get a 12-lead EKG. Those are the three things we're going to look at and say, are you having a heart attack or not? Now, fundamentally, as a nurse, I don't diagnose people, but I'm smart enough to look at all those and go up to my healthcare provider and go, hey, you need to come in this room right now because I got a problem. Okay? Three things you're going to look at: signs and symptoms, troponin, EKG. All right, so pharmacology comes next. So I've listed the medications that you might see. So we give nitroglycerin. It's a vasodilator. It dilates the coronary arteries so that we get more blood to the heart, and we can stop that chest pain, chest discomfort, because they're hurting because their heart doesn't have enough oxygen. Now, it also lowers your blood pressure because it's a vasodilator. It decreases preload and afterload, so it decreases that resistance the heart has to work on because it dilates. It decreases preload because it helps offset that volume. And we can give it sublingually, and we can also give it in a continuous medication infusion called an IV drip. The trade name for that is Tridil, but we're going to use the term nitroglycerin. And if you're going to hang nitroglycerin, what do you need to check frequently? Their blood pressure. An expected finding is if they have a blood pressure of 145 over 100 and I give them nitroglycerin and I recheck their blood pressure in 5 minutes. Number one, I want their chest pain to be gone. Their chest pain should be 0. There is no other goal for a patient with unstable angina, coronary artery disease, or having an MI. It's 0. If I come back in 5 minutes, I would like their chest pain to be gone. If not, I need to do further treatments. I would expect their blood pressure to go down. It might be 128/92. That is an expected finding. I would not expect to find a blood pressure of 90/40. That would be an unexpected finding. So we will give nitroglycerin. We're going to give morphine. It works by vasodilation as well, and it reduces preload. And we're, like I said, going to have a pain goal of 0. Now let's go to oxygen, because what I have up here is MONA: morphine, oxygen, nitro, aspirin. It's an easy way to remember what you give. It's not the order of what we give. So evidence now says that we only put oxygen on people who are in respiratory distress and are breathless and have low O2 sats, heart failure, or hypoxemia. Otherwise, they don't need oxygen. That is the standard of practice. It's been there for a long time. That is what we teach across the disciplines of health science. But I will tell you, you will still find NCLEX questions that are going to ask you to put oxygen on a patient. Now, I don't know what the NCLEX is going to say about that. I don't think that they're going to get real specific with that. But the standard is, if they are not having breathlessness, signs and symptoms of respiratory distress, we're not going to give the oxygen. So you can think of MONA, but you just got to think about the A. So nitro for the N, morphine for the M, O for oxygen, and then A is for aspirin. It inhibits platelet aggregation, because remember, when that plaque ruptures, the platelets are going to go over there and make a clot. It's not going to stop the clot. It's not going to make their MI go away, but it's going to make the platelets less sticky. So they're going to get that. It's given immediately to all patients who we think are having an MI. And you will find that people take it before they come in, because everybody in the world knows that they now need to take nitroglycerin, or take an aspirin. You're going to follow your healthcare orders, because they may say give them an adult aspirin. They may say give them 2 or 3 baby aspirins, have them chew it up, whatever it is that they order. They may be given a beta blocker. Beta blockers reduce morbidity and mortality after an MI. It reduces the oxygen demand of the heart. But remember, when you give a beta blocker, their heart rate goes down and their blood pressure goes down. Typically, we're seeing metoprolol, atenolol are the common ones. Long-term use of beta blockers is really now being researched again, and most patients beyond a year's time are not continuing with the beta blocker unless they actually have heart failure. That seems to be the new standard and the new evidence. We may give them ACE inhibitors to reduce the incidence of ventricular remodeling. That's the heart ventricular walls getting thick and ballooning out, which means it doesn't pump well. And we give that if they have an ejection fraction less than 40%. And lisinopril and captopril are probably the most common beta blockers we're going to use. Antiplatelets, anticoagulants, so we may start them on a heparin drip. The 2 most common antiplatelets that we see are ticagrelor and clopidogrel being given. And those are given when they come in. They can be given in the cath lab or shortly after the cath lab, and they will be continued for at least 6 months to a year afterwards. And then in Amarillo, Texas, we do see that they are continued longer. So if your patients are going home taking these antiplatelets, aspirin plus ticagrelor or clopidogrel, think of the teaching that we need to do for those. If they have dysrhythmias, we'll use antidysrhythmics like amiodarone or lidocaine. That'll be more in your dysrhythmia content. And then certainly we're going to have them on a statin to reduce those lipid levels. Rosuvastatin's fairly common, simvastatin's common as well. And think about what we have to teach based on a statin. They may have muscle pain, which isn't really okay, can be intolerable for them, which means we have to change their statin, but these patients will tend to go home on statins, and that does mean that they have to follow their diet. All right, so your treatment for an MI, think of Mona. We need to restore blood flow to that myocardium, which means we need to take them to the cath lab and do a PCI, percutaneous coronary intervention. That's the primary treatment for these patients. So we will talk about that in our next recording.